Welcome to the Core Ultrasound podcast. I'm your host, Jailyn Avila, and today I'm joined by Dr. Sophia Fornbacher. In this episode, we're going to explore her personal and professional journey of a physician who has trained in multiple different areas, how she navigated the challenges of the COVID-19 pandemic, discovering a passion for bedside ultrasound, and building a career in emergency medicine. Together, we discuss resilience, mentorship, and the unique experience of women in this demanding field. From overcoming self-doubt to finding joy in ultrasound as both a tool and a teaching platform, Sophia's story exemplifies perseverance, purpose, and passion. Check it out. Hello, my name is Jailyn Avila of the Ultrasound podcast. I'm here with Sophia Fornbacher, who I met around 3 years ago. And we've been ultrasound friends, I say, and regular friends ever since. It's so much fun to run into you at the regional events that we kind of interact with. Sophia, how are you today?
I'm doing great, and I will say I love bumping into you. It is always a great time. So I'm very excited to be here chatting with you today.
Yay. Sophia, where are you from? Where did you go to, college? Where'd you go to med school? Where'd you do fellowship, residency, all that stuff?
Oh man, it's been a journey. Let me tell you, girl. So I grew up in the East Bay area, about 30 minutes east of San Francisco, spent most of my life there. I went to college at a really small university out in Tennessee to play college soccer. And then I went to Boston University School of Medicine for med school. So I kind of went all over the country. I've been a little bit over here, a little bit over there, but I really wanted to come back home for residency. And I was fortunate enough to match at Harbor UCLA, which is a 4-year program at a county facility down here in LA. And then I just finished up my ultrasound fellowship at Riverside Community Hospital, and I have been fortunate enough to be offered to stay on as ultrasound faculty there.
Yay. Now, Sophia, besides the fact that I like having an excuse to talk to you and to learn a little bit more about you. One of the reasons that we're doing this is because we want to make sure that we are supporting all of our attendings, residents, all of our ultrasound faculty. And I remember reading a statistic recently that said that the average, we'll say, career span of a female emergency medicine physician is around 10 years. And I think that's for the amount of work that we do and the amount of, issues that we have, heartache, lack of sleep, debt, all that stuff. I want to do everything that I can to help us last longer in medicine, help us deal with these issues. Mm-hmm. And I've had conversations with you in the past, and I just love your insight, and I think you have a great story. And so my first question for you regarding that is, you just finished residency. I finished residency in 2015, I think, 2015. So it's been around 10 years for me. And so part of me wonders, and I went through residency in a kind of, we'll say, a different social space, but you just finished up. What helped you get through your emergency medicine residency?
Yeah, I think first and foremost, having supportive people around you really makes such a difference. And we all fight our own internal battles, and being able to share that with others is really essential. There's been a few things that have really helped me get through residency. First and foremost, finding moments of peace in the busy hustle. I started residency in 2020, which that was peak pandemic time. And I really had a hard time during the pandemic. I was on the ICU as an intern, and no matter what we did, my patients didn't make it. And so I was really having a hard time questioning, what are we doing in medicine if people aren't getting better? And I'm calling families every day to tell them that their loved one's not doing well. I'm telling family members, my patients, that they should call their family members before we intubate because they might not wake up again. And it really left me in a space where I was ready to leave medicine by my second year. And I just didn't want to do it anymore. But realistically, like you mentioned, we go through so much to get to where we are. And I was like, listen, I finished medical school. I have debt. My family's depending on me to build this career and provide. So I have to get through this. But what really kind of brought me back into medicine and really enjoying it again, despite these challenges, was honestly ultrasound. It started at first with me just needing to get my numbers for residency, but I started just picking up the probe and bringing it into rooms for patients who were doing fine, your epigastric pains, and just show them their gallbladder. Look, there's no stones. Or if a patient's really worried about their kidneys, I'll just show them their kidneys and educate them a little at bedside. But through that, I found a lot of joy. I saw, my patients, I can see them feel better. I can watch that happen, the light up in their eyes. And that made me feel better as a provider. So I started doing that more and more. And gradually, I started teaching my more junior residents as a senior resident. One case in particular that I always think of as the moment that I went into fellowship or wanted to do fellowship was I had a pretty sick patient with one of my residents. We thought it was septic shock. And I said, you know what, let's just put the probe on there. Let's just see where we're at. This patient had a really plump IVC, beelines everywhere. We ended up chatting with our attending and pushed Lasix instead of fluids. And I remember the intern looked up at me and said, Sophia, that was so cool. Like, I had no idea ultrasound could change your management like that. And that was another moment where I realized, okay, teaching ultrasound, having this tool with me really has ignited a new passion for me. And so that really picked me up and gave me a lot of the encouragement I needed to continue forward.
Brilliant. I've actually learned that myself. I've realized that I've scanned, I don't know how many, like hundreds of thousands of patients since, I started, since I first held a probe as a fourth year medical student. And so far, I've only ever had two patients, even if it's like an educational scan, it's like, hey, I just want to check something. I've only ever had two patients say like, no, I'm good. Most of the time patients are excited and you have a little more time to actually connect with them. And it's not just you like sitting. Cause for me, sometimes I get anxious if I'm not doing something clinical, like I get a little anxious about, I need to do something, I need a chart, I need to order something, I need to follow up on test results. Whereas when I'm ultrasounding, I'm actually doing a test, interpreting it at the same time and helping solidify my connection with the patients, and patients do like it. Ultrasound, doing bedside ultrasound has been shown to actually increase the satisfaction rate independent of like outcomes, even though I believe that it does help outcomes, right? And there is some data that shows that objectively.
Absolutely.
But it's more than that. It's patients like it. It's more information for us. And I think it makes us better physicians because we can be more specific with our testing. And that's, that's with diagnostic. I mean, therapeutic, that's a whole nother thing, right? Because the best skill that I have, honestly, I think, is the ability to place an ultrasound guided IV, because that is, I think, I lecture this way, that I think ultrasound guided IVs are the most difficult procedure that exists in emergency medicine. I mean, yeah, if you have like a really easy IV, that's one thing. But if you take the average ultrasound guided IV in someone that the nurses have tried, other people have tried, that procedure is so much harder than the average central line or the average nerve block, for instance, or the average really pericardiocentesis. So I think if you get a good window, like someone's in tamponade because they have a big enough pocket, like ultrasound guided pericardiocentesis, it's scary, but it's really not technically challenging relative to a difficult ultrasound guided IV. And patients like it because it hurts them less, and it pokes them less and all that stuff. And I think it has also helped me in my career to have longevity. So I very much agree with you, and I've had a similar experience for sure.
Yeah, I love it. I agree completely. I tell all my interns and med students, like, if you can do an ultrasound guided IV, you can do any other procedure out there. It is truly one of the toughest, but it is an essential
Absolutely.
tool.
It is. It's important, and not a lot of people have it, and it takes skill. One of the lectures, actually, usually the lecture I give, towards the end, I will say, I will have a big slide. It says 0/10, like 0 to 10,
Yeah.
because I haven't been unsuccessful in quite a few years. Like sometimes it'll take me two sticks, but I can usually get it, even if it's small. But my 11th attempt was the first time that I had a successful one that didn't pop out or that didn't extravasate. So it's really hard, but it just takes practice. It's about reps. Now,
Absolutely.
what would you what would you tell baby doctor intern Sophia to help her get through residency a little more smoothly? Not
Yeah.
saying that you had any issues, right? But like I always think, like,
Oh,
how can
girl.
we make the process easier, right?
Absolutely. Absolutely. I think, um, kind of like you were speaking on earlier, I think a lot of us in the ER, we want to do something. We want to do something to help. And we feel like, I mean, I don't know about you. If I'm on shift and I'm not doing anything, let me go home. I'm here to do things. Okay. And
Right.
I think I really struggled as an intern because we were doing things and it wasn't working. And I just felt so frustrated. I was like, what is this? But I think what I would tell myself in those moments is actually that the moments where I feel like I'm not doing anything, my presence is still doing something. So even in those moments where the medical interventions weren't working, the time that I took to sit and talk with those family members on the phone, on the FaceTime at the time, with the pandemic, like that was doing something that, while it's not necessarily tangible, you can't measure it, but just being there and being present in that moment is another component of our job as physicians. We don't always have to do something. Sometimes we just need to be there and acknowledge what's happening and inform our patients and their family members of what we understand so that they can prepare and manage in the best way that they can for whatever's going on. And I think now when I look back, I cherish the moments that I had, even though I was struggling. But I was really there for a lot of essential moments for people and for family members and my patients. And I'm glad that I was able to be there.
I It's easy to focus in on negative kind of interactions that we have or negative cases. And I feel like that's, in a sense, I almost feel like that's human nature. But one of the things, and I think you're alluding to this, that I kind of focus on and I tell the residents is when we have those wins, when we have those cases where the patients are thankful, they're happy, the times where we, do there's a near miss, like
Mhm.
somebody that we're about to treat for sepsis, but it turns out that they have heart failure. Hold on to those and focus on those rather than the negative things. And this is not to say like we don't make mistakes, don't learn from our mistakes. Like we
Right,
definitely
right.
should learn from our mistakes. They're an amazing teaching
Absolutely.
tool.
Hmm.
But the focus should be on the good things that we do and not on the bad things that we can do. And that has also helped me dramatically in my career.
I agree completely.
Now, how can we help advocate for other women in emergency medicine and in the ultrasound community? And what can others do to help us and to advocate for us?
Yeah, I think that is a great question. As women in emergency medicine in particular, I think there's always a challenge because you may not present how others expect you to present, right? You go to the ER, and a lot of people kind of have this expectation that their doctor is going to be an older male, maybe of a particular demographic. And then here we come in with, our super cute lipstick and eyeliners
Mm-hmm.
and positive energy. And oftentimes people may kind of question your decision making or kind of what you want to do. In the moment, it can kind of maybe feel like an individual disrespect type of thing. But in these moments, I do try to remember that, look, in the ER, we're all a team, from our environmental health services to our nurses to our techs to our physicians. We're all here with the same goal. And ultimately, we're coming from the same place. We want to help our patient and we want to get them to where they need to be. Um, I did have a case where I had an attending really kind of help me advocate for myself in a way that I didn't quite understand in the moment. But now when I look back, I realize that actually what he did was very empowering. And so, in brief, there was a patient who was in really bad heart failure. They were hypotensive. I spoke with my attending and we wanted to give Lasix. They were super volume overloaded. Their pressures were like systolic 90s, a little soft. And I told the nurse at bedside, I was like, hey, we're going to push like, 60 or 80 of Lasix. And she expressed concern. She was like, hey, doc, the pressure is very low. I don't feel comfortable giving this medication. I don't think we should do it. Can you speak to your attending? I just want to make sure that this is the plan. And I was like, yeah, absolutely. And of course, like I was, I think, a third year resident. So I'm tired. I'm working 6 shifts a week. I've got like 10 other patients. And like, I'm feeling upset that this person is not taking what I'm saying to be, the next best step. And it kind of hurts your ego a little bit, not gonna lie. So I go tell my attending and I'm like, hey, this nurse won't push the IV Lasix. I know we talked about it. Do you mind going over there and talking to her, to get her to give it? And my attending says, no. He says, look, you are a senior resident. I was at a 4-year program. He's like, you have one more year. You know what you're doing. We talked about this case. We know what this patient needs. And you need to learn how to communicate with your team so that you're all on the same page, because you're going to face this again and again as an attending. So I went back over there and I spent some extra time with the nurse, and I kind of explained to her more of my thought process. I talked to her about what the next steps were if the patient did become hypotensive, and gave her a plan of action. And then she agreed, and we pushed the medication, and ultimately, we got the patient on BiPAP. They did a lot better. But I think something to really keep in mind is when people are doubting you, we've all been there. The essential part is, what does the patient need, and how can I get all of us on the same page so that we can make this happen? So whenever I have critically ill patients, I do like to try to talk to my team, my nursing staff, my techs, and everyone, and give them a game plan. And a lot of times, if someone is expressing concern for you or for the plan, you just need to talk to them and address their concerns. At the end of the day, we all have the same goal.
It's a very mature way of looking at it, honestly, and it's difficult for a lot of people to get there. And the way that you're dealing with that, or the way that you've learned to deal with that, is stuff that I think it's not unique to emergency medicine as far as how to deal with issues. It's like life in general, where
Absolutely.
most of the time when we have negative, we'll say, interactions, or we're invalidated one way or another by others, frequently it's a problem of either what they know or some bias that that person has.
Absolutely.
They're not necessarily trying to make Sophia feel bad or trying to make Sophia feel like she's not respected. It's just the nurses, and really any colleague, because I've had these issues with attendings now, is that they automatically assume, because I'm bright and cheery and I wear makeup and I'm often wearing pink on shift, that I don't know why I'm ordering something, where in fact I know exactly why I'm ordering it. I've thought through it. And so if I just stop and explain to them why, or if it's a consultant and I say, hey, listen, just a reminder, I'm asking you for help. I also don't work for you.
Absolutely.
I'm your colleague. And sometimes doing that, and I never say it, I never scream back. I'm not saying it to be mean. I'm saying it to help recenter. And once I kind of gave myself the permission to do that, to colleagues in the ER and sometimes even to patients, I'll say that my stress level has dramatically gone down, because I feel empowered to advocate for myself and for my colleagues that I see, if they happen to be having a similar issue.
I agree completely. And I think that this is really an essential skill to kind of teach our learners, right? Our residents, our medical students, because they'll face similar things. And I'm really grateful for how my attending handled that situation, because he really empowered me to just stand up for myself. And I absolutely felt supported knowing that he validated my medical knowledge and my plan, but he emphasized that I now have to learn how to communicate this and make things work. And so, like, additional ways is like, I think a lot of times I really look up to you and you do so many amazing things, but we do face similar challenges. And I think it's important for our learners to understand, like, I also wear very bright colored scrubs. I have Jurassic Park themed socks. Like, it's a whole thing. You kind of can't miss me on shift. But I do like to tell my residents and my med students, like, hey, I face challenges too. And when my patient is sick, I get worried too. Like, I'm not just chilling. And I think sharing those vulnerable moments is another important way to empower others, because it at least opens the floor for communication and connection, which we all need in what we do.
All right. Well, I hope you have a great rest of your day, and thanks for hanging out with me today.
Thank you so much for having me, and I hope you have a wonderful day as well.
That wraps up my conversation with Sophia. She's such an amazing person, and her story is incredible. And it serves as a reminder that the challenges of medicine can also be opportunities for growth, moments to find renewed purpose, to advocate for one another, and to create a more supportive community in emergency medicine. If you enjoyed this episode, be sure to subscribe to the Core Ultrasound podcast and share it with a colleague. You can also explore more ultrasound education resources at coreultrasound.com. I hope to hear from you soon, and happy scanning.